Hi, everyone. We'll start with today's specimen. And I'll put up our first polling question now. What type of specimen is this? Okay, and I'll end the polling there. So the correct answer for this one is in fact a simple mastectomy specimen. So it looks like the majority of you got that correct. So now we'll go through the different types of mastectomy specimens that we can get. So our first one here is the simple mastectomy specimen, and that's what we have here. So it just includes the breast tissue alone. Our next one is a modified radical mastectomy specimen. So that would include the breast tissue as well as an axillary tail dissection. And the last one, which would be removing the most tissue, is the radical mastectomy specimen. So that one would include the breast tissue as well as axillary tail dissection and pectoralis minor and major. So we get mastectomy specimens for multiple different reasons. So we can get them out for prophylactic reasons. So if the patient has a family history of breast cancer, or if they have genetic syndromes that predispose them to breast cancer. We can also get them out for completion mastectomies. So that would be for if a patient had a previous lumpectomy and the margins were positive, and then they're going back and just getting the entire breast removed. We can also get them for post-neoadjuvant chemotherapy. So if the patient has breast cancer and they're being treated with chemotherapy. And then lastly, we can get them out for malignant lesions. And that's what we're going to be primarily focusing on in our talk today. So now we're going to go into how to open/fresh these mastectomy specimens. And no matter why they're taken out, we do the exact same procedure for every single one of them. So I've made a few short video clips to demonstrate the different steps that are involved with breast freshing. First off, we want to start by checking our patient identifiers to make sure that the specimen that we have matches all of our containers and our requisition. We also want to make sure that our orientation makes sense. So if the surgeon has said the short suture usually is superior, that we see that there, and then the long suture for lateral. We'll also be wanting to take the weight at the time of freshing and take overall measurements of the breast specimen, the skin, and the nipple. So now I'll play this video here and you can see the specimen in 3 dimensions. So you can see our anterior view here with orienting sutures. And then this is our posterior view here, which will have a fascial layer that we'll have to be cutting through when we do our breast freshing. So our next step will be inking. So at our institution, we do blue for superior, green for inferior, and black for posterior. If your institution does different inking, just follow the SOP that your institution has. And a good way for us to remember for our inking is blue is for sky, green for grass, and then black is just posterior. With our specimen here, we also have an axillary tail dissection. So this one would be a modified radical mastectomy. So there's a few different things that you can do for inking for this axillary tail. So you can either include it within the blue ink of the superior portion, or you can ink it a separate color. I usually like to do orange if I'm doing it that way. In this case, I just left it uninked so that I allowed the person that will be grossing it the next day to decide how they want to ink it. So now I'm just finishing up with the inking part, and you can see that every aspect of that breast tissue is covered in ink. I don't have any exposed breast tissue. And I'm going to spray it down with acetic acid, and that just helps to let the ink really stick onto the tissue. And now I'm patting it dry. And I want to make sure that the specimen is really dry before I make any cuts. If I try cutting it when the ink is still wet, that ink's going to actually run right into the breast tissue. Now that the specimen's all inked, we're going to move into the cutting. So I want to make sure that I leave my end margins, so my medial and lateral ends, a bit wider, about 2 centimeters. And then my in-between slices, I'm aiming for 0.5 centimeters in thickness. And I want every slice to be even thickness. And I want to be cutting all the way down to the back of that skin that was on the anterior side. So if you imagine, it's kind of like a book with the skin being the spine of the book, and then the slices that I'm creating being the pages of the book. To get these nice slices that you can see that I'm getting here and keeping all the margins on, I have a few tips and tricks to give you guys for this. So first off, making sure that your blade is really sharp. So if you notice that halfway through cutting that your blade is getting dull, don't be scared to get a new blade and change that out. Also going with enough pressure to get all the way down to the skin so that you don't have to be going back and making multiple additional cuts through the same slice will help you with making the slices very smooth and even. I would also suggest going faster rather than slower. If you go slow, you can sometimes get hesitation marks throughout the tissue, and that will lead to uneven slices again. Another thing is sometimes you get these really floppy breasts where it can be really difficult to make nice even cuts. So I will actually use kind of a sponge to help prop up the specimen a bit. Like this here, just to hold it kind of more in place when I'm doing my cutting. So when I do my cut, the tissue doesn't all just fall apart. It's important though, if you're using the sponge or even when you're using your hand to hold here, that you're not pushing the specimen over at all like this, because then your cuts will become more on an oblique angle versus actually straight up and down. So now I'm just going to go back in and clean up all my cuts. So I want to make sure that everything's cut fully through to the back of the skin. And then as well, my tissue that's superior and inferior is fully cut through as well. I'm just going through and cleaning up all of those slices. And you can see there, it's cut down all the way to the skin. And the reason it's so important that it's cut all the way to the skin is that if you don't do that, you end up getting really wedge-shaped pieces of tissue. And that can be really difficult when you're trying to gross a specimen because it's so uneven that you'll have a larger anterior margin and then a small little posterior margin. Our next step that we do is putting in paper towel in between each one of the slices. So this just allows for the formalin to really penetrate into that breast tissue. And it's really important when I'm putting these slices down onto the paper towel that I'm not pulling and distorting the breast tissue. I'm just gently laying the breast tissue down on the paper towel and not distorting the shape at all. So I would continue doing that throughout the rest of the breast specimen. Here we have some photos just of the aftermath of that. So the one photo showing the posterior aspect and then the other showing the anterior aspect. And you can see that the skin is primarily intact. I've just cut through a little bit on the inferior aspect and the superior aspect, and that's completely fine. The main thing that we want to try to avoid is cutting all the way through that skin, because then you're going to have floating bits of breast tissue in the specimen container. And it's going to be really difficult for the person that's grossing the case to know exactly where those tissue pieces came from. When we're talking about freshing, it's also important to understand the CAP guidelines associated with it. So I'm going to bring up our next polling question here. So CAP guidelines on breast cancer currently recommends a cold ischemic time of Okay, so I'm going to end the polling question there. And here are the results. So it looks like most people did get it correct. So it is in fact less than 1 hour. Cold ischemic time is the time that tissue is removed from the patient and then placed into formalin. It's really important that this is kept under an hour because researchers have found that over an hour has negative effects on immunohistochemistry, which is used to examine breast biomarkers ER, PR, and HER2. As well, accurate results of these biomarkers are very important in patient care as they allow for patients to get targeted treatment. Now we're briefly going to go over some information about breast cancer. So breast cancer is the second most common cancer among Canadian women, the first being skin cancer. It's estimated that about 1 in 8 Canadian women will develop breast cancer during their lifetime. Breast cancer can get broken down into 2 different groups, so it's either non-invasive or invasive. So non-invasive includes ductal carcinoma in situ, lobular carcinoma in situ, and it's non-invasive because it hasn't broken through that myoepithelial layer yet. The cancer cells are still confined to that inside layer. Invasive cancer is when the cancer has actually penetrated through that myoepithelial layer and has invaded into the adjacent stroma. So invasive ductal carcinoma, no special type, is the most common, and it accounts for 70 to 80% of breast cancer. The remaining types are broken down into special types, and those ones include lobular, medullary, mucinous, tubular, and a bunch of others that we're not really going to discuss in this presentation today. So now for our case, the history for ours has been biopsy-proven invasive ductal carcinoma, no special type. So that's the one that we're primarily going to be focusing on in our presentation today. And it's the most common type of invasive breast cancer, so it's the one that we see most often. For gross features, it can vary in appearance, but usually it's very white and firm, and it either is lobulated or more of a stellate appearance. So you can see the one picture is showing more of a lobulated appearance, and then the second picture is showing more of a stellate appearance there. And now we'll go through our breast specimen here, and I'll show you what our invasive ductal carcinoma looks like. So you can see here that it has more of a stellate appearance. This firm area here, it's very firm to feel versus the fibrous tissue that's adjacent to it right here. This is more rubbery. So that's a good indication that this is in fact my mass. And there. So some risk factors associated with invasive ductal carcinoma include hormones, reproductive factors, diet, environment, and genetics. I'm going to put up our next polling question here. Which gene is not associated with an increased risk of invasive ductal carcinoma? So I'll end the polling there. So most of you did get it right. So it's not associated with CDH1. In fact, that one's associated with lobular carcinoma. So I'll go back and kind of touch base a little bit about those other risk factors that we mentioned. So for hormones, prolonged estrogen exposure leads to an increased risk factor. As well, reproductive factors, so women who have not had any children, women who have not breastfed, and women who have their first child over the age of 30. And that's again because of that prolonged estrogen exposure. For diets, obesity and alcohol consumption leads to increased risk factors. And then for environment, women in North America and Europe have a higher risk of breast cancer. Genetics, if a family member has breast cancer, then the other women in the family are at also an increased risk of breast cancer. If the woman has a mutation in BRCA1 or 2 genes, then they have an increased risk of about 20 to 60% for familial breast cancer. Germline mutations for P53, which is Lymph syndrome, these patients have a risk of about 25%. And for Cowden disease, which is the P10 mutation, those ones have an increased risk of about 30 to 50%. Now we'll go through a few differential gross features. So what some of the other types of lesions would look like in a breast. So this one here, you can see it's a very well circumscribed white lesion. This one is a fibroadenoma, which is the most common benign tumor within the female breast. Our next pictures here, you can see that there's this kind of like pale yellow, pale tan speckling throughout on both images there. So this one is showing DCIS, ductal carcinoma in situ. And sometimes you won't be able to see this grossly, and other times this would be kind of the appearance that you would be seeing, this speckly appearance. So now we're going to talk about invasive lobular carcinoma, and I'll put up my next polling question. So what does invasive lobular carcinoma look like grossly? Okay, so I think I'm going to end the polling there. So it is in fact all of the above. So lobular carcinoma can be a really tricky one to identify grossly because it can either look like a nice obvious mass, or it could look like rubbery fibrous tissue, or more fibroadipose tissue. And here's the image here. So you can see that it kind of has a mixed appearance. It looks similar-ish to the mass, but then also still more like, feels like more fibrous tissue. And this lobular cancer can actually be expanding out further into that adipose tissue there that looks completely normal. So our next image here, I'll put up our next polling question. So what type of malignancy is shown in this image? Okay, so I'll end the polling there. And yes, it is mucinous carcinoma. And you can tell that because of the very mucin-like appearance of this mass. So now we'll go through briefly some steps that are important to go over before we actually start grossing the specimen. So it's really important that we review all clinical history, and this will include looking at imaging to identify the number of lesions, the location of these lesions. As well, we'll want to go through the operative report to confirm the type of specimen that we have, as well as confirm the orientation. We'll want to be looking at the pathology report to look at the previous biopsy results to identify what type of cancer this is. So if it's invasive lobular or invasive ductal or DCIS, that's going to affect the way that we gross the specimen. So a lot of times when you're looking at those radiology reports, the radiologist is saying that the mass is on a certain radian. So the 3 o'clock radian or the 6 o'clock radian. So to understand this, you want to imagine that you're looking at the patient and that there's 2 clock faces on their breasts, with the nipple being the center point and 12 o'clock being the most superior aspect, and you go around in a clockwise fashion. Another way that the breast can be broken into different areas is when it's broken into quadrants. So it can be broken into 4 quadrants, again, using that nipple as the center point. So it can be broken into the upper outer quadrant, upper inner quadrant, lower inner quadrant, and lower outer quadrant. So for our breast here, we have our lateral suture here, our superior here, our nipple here. So this would be our kind of midpoint. So I would know that my cancer here would be in the upper inner quadrant, because this would be the outer region and this would be the inner. So I would go, this would be upper inner, lower inner, upper outer, and lower outer. So I'm going to put up our next polling question here. So where is the most common location for breast cancer in females? Okay, so I'll stop the polling there. So it looks like most people did get it correct. So it is in fact the upper outer quadrant. So males can also get breast cancer, however, it's far less common. And for males, the most common location is the retroareolar. So now that we've gone through kind of all the basic background information and all the steps prior to grossing, we're actually going to go through the specific steps for grossing these specimens. So our steps include identifying what the specimen is, talking about the main findings, additional findings, ink code, and section code. So here's a sample gross description that I did. So we want to say what the specimen is. So a right simple mastectomy specimen. We'll give the weight in grams, and that will be taken at the time of freshing. So it should be pre-fixation. And then we'll also be giving the overall measurements. So measuring the medial lateral measurement, the superior inferior measurement, and the anterior and posterior measurement. We'll also be giving a measurement of the overlying skin in 2 dimensions. So we'll do medial lateral and then superior inferior. And then as well, we'll give a measurement of the nipple in 3 dimensions. We'll also be talking about the orientation, so how the specimen has been oriented as per the requisition. And I also like to include in this portion how my specimen was sectioned. So if it was sectioned medial to lateral or lateral to medial, and how many slices it's generated. So that would just be how many of these slices there are. I also like to give the thickness of each one of these slices, and it's really good idea to include this, especially if you have a case that's out for DCIS or lobular carcinoma, where you might not be able to see it grossly, then the pathologist can get a better accurate size of that mass when they have to do the calculations. I also put in where the nipple is located, so which slice. For slicing these specimens for grossing, there's a couple different ways that we can do it. The first is that we can leave it intact like this and just gross it, kind of keeping it in that book formation with the pages and the spine. And I would recommend this approach only when you have a big obvious mass that's easy to see and identify. The other way that we do it more often at our institution is actually completing each one of the slices. So I would cut through the skin for every one of the slices and then lay it out, going either lateral to medial or medial to lateral, and making sure to number all the slices. This way, it's just really easy to identify any smaller lesions or any like firm fibrotic areas, and you can get better visualization of the breast tissue. So now we'll move on to talking about our main findings. So we'll want to describe the lesion. So that will be describing the consistency, the color, things like that. So for this one that we have for our case, it's very firm, white, and stellate. And then I would be giving the location. So I would say that this one would be in the upper inner quadrant. I would be giving all my distances to all my margins. And then if I were to have multiple lesions, I would be wanting to talk about the second lesion as well and giving the distance in between the 2 lesions. So if the lesions are less than 0.5 centimeters from one another, it's a really good idea to also include a measurement of those 2 lesions together. So doing individual measurements and then also a combined measurement. And this will just be important because for staging purposes, they're going to take that overall size of both of those lesions if it's less than 0.5 centimeters from one another. Another thing to mention in our main findings would be if we identify any biopsy clips or biopsy sites. So you can see in the PowerPoint image there that adjacent to the mass is kind of this little like gelatinous area. So that's actually a biopsy cavity, and it's filled with gelatinous material. And most likely I would find also a biopsy clip within that area. Our specimen here, I'm not really seeing any biopsy site or biopsy clip right off the bat, but I might find it when I do my sectioning. So here's just an image just showing all the different types of biopsy clips that we can get. The one shown in the image there is the ring biopsy clip. And that one's probably one of the larger ones that we get. The smaller ones, like the top hat ones, can be pretty difficult to identify grossly. So here's a sample gross description of the main findings portion. So I'd again want to be talking about that shape, color, consistency, the overall measurement of the mass, so in 3 dimensions, the location, so which slices and which quadrant, and then the distance to all those margins. As well, the distance to the skin and the distance to the nipple. So this one's still pretty far from that skin. You can see the skin there. And then from the nipple. So we also want to talk about our additional findings. So we'll want to describe the non-involved breast tissue, describe the skin and the nipple, and describe the axillary tail if we have it. So within the axillary tail, we would be expecting to find lymph nodes. So we want to mention how many we're finding and what their size range is. So here's a sample gross description of the additional findings paragraph. So I would say that the tissue consists of approximate percent of fibrous tissue to approximate amount of adipose tissue with no other masses or lesions identified. I'd say that the skin is unremarkable and the nipple is inverted. So for this one, we'd want to be looking at how much fibrous tissue we have. So that's all of this white kind of rubbery tissue throughout. And then the adipose tissue is more of this yellow coloration here. So for this one, I would say that there is probably about 20% fibrous tissue and 80% adipose tissue. And then we also have here our nipple, which is inverted. So for inking code at our institution, like I mentioned before, we do black for posterior, blue for superior, and green for inferior. If we don't have skin, so if we have a skin or nipple sparing mastectomy specimen, we're going to just go halfway down the specimen and do the blue and the green also on the anterior surface. So if we don't have any skin, then that will also be included. So it will be blue superior / anterior and then green inferior / anterior. Now we'll get into sectioning. So how we'll section these specimens. So if we have a nice mass like the one that we have here, we'll want to be doing 1 section per greatest centimeter of the mass. Unless the mass is really small and it can fit into like approximately 5 cassettes or less, then we can submit the mass entirely. We'll want to include any close margins. So for this one, I can probably get a nice section of the mass with the posterior margin there. If I can't get it in 1 section, then I'll just be taking representative just to show that those margins are clear of any cancer. I'll want to include sites of the biopsy clip and then sample any areas in between lesions. So if I have multiple lesions, I'll want to take a tissue sample in between those two, just to make sure that it's not one contiguous mass, basically. If the skin is really close, then I'll want to take a section of the overlying skin. And then I'll do 1 flanking slice before and after the mass. So if the mass is in these slices here, then I take a section here and a section here. And that would just be to make sure that the mass isn't extending further than I can see grossly. So for comparison, I'll just go through kind of how we would section a DCIS case as well. So we'll want to focus on sampling the biopsy site and the surrounding fibrous tissue, because like I mentioned before, DCIS can be very difficult to identify grossly. Sometimes you won't be able to see anything, and other times you'll be able to see a bit of that pale yellow chalky speckling. With DCIS, it's really important to document the overall size of the area. So we'll want to be sampling a full face section of the largest area. And we'll want to be submitting any close margins. So any margins that are close to like that fibrous speckled area. And then sample the tissue between biopsy sites. So if there's multiple different biopsy sites, we'll do another sample in between those. And then we'll do 2 flanking levels before and after the suspicious area. And we just do 2 because it's those cases where you can't really see it grossly. So our sections for our non-involved breast cancer would include 1 section per each quadrant. And we want to focus on the dense fibrous tissue, particularly near the margin. So I'd want to maybe be taking more sections kind of this area, where it's pretty close to that margin there, versus kind of just this fatty area here. That's not going to show us as much. And then for the nipple, if it's normal, I'll do 1 perpendicular section. If it's abnormal, then I'll submit the entire nipple perpendicularly. If we find any lymph nodes, we'll want to submit all lymph nodes. So sometimes you can find interparenchymal lymph nodes, especially within the lateral aspect of the breast. So just keeping that in mind. And then as well, if we have the axillary tail dissection, we assume that we would find some lymph nodes in there. So now that we've done all of our sectioning and we've completed the case and put all of our samples through that we want to wrap up the case. So we want to wrap it up in organized fashion so that we can go back to the case in case we need to take additional sections. So if we were to just throw all these pieces in the bucket, you can imagine that it would be very difficult to identify where you took which section. So I really like to lay them all out on the mesh piece of cloth, number them, keeping the same orientation that I used for grossing, and lay them all out nice and even. Then I kind of wrap it up into this little burrito here. So now we'll go on to staging. So I'll put up our polling question here. So what PT stage is a tumor that measures 5.0 centimeters in greatest dimension? Okay, and I'm going to end the polling there. So it looks like most people picked T3. That's not the correct answer. This was actually a little bit of a trick question for you to really test you on your staging. So in fact, 5 centimeters is actually T2. So if you look at the chart here, T1 is less than or equal to 2 centimeters. T2 is greater than 2 centimeters, but less than or equal to 5 centimeters. And then T3 is greater than 5 centimeters. So if you had a mass that was 5.1 centimeters, then that one would be a T3, but 5 centimeters would be a T2. And then T4 has to do with extension into the chest wall or into the skin, showing ulceration or skin nodules. And it can be broken down into A, B, C, or D, with D being the most or the worst as inflammatory carcinoma. So now we'll go through some of the lymph nodes that you can get with mastectomy specimens. So you can get axillary lymph nodes, and these ones can come either as the axillary tail dissection, or you can get them into separate containers that the surgeon has indicated which level they are. So level 1 is below the lower edge of the pectoralis minor muscle. Level 2 is underneath / posterior the pectoralis minor muscle. and level 3 is above/medial the pectoralis minor muscle. Most of the time, we'll only ever get levels 1 and 2 unless there's clinical suspicion for level 3. We'll also usually get sentinel node biopsies. So sentinel node biopsies are really important to understand if the tumor has spread at all. So they'll insert radioactive substance or dye into the breast and then track to see where that flows into the first draining lymph nodes. Those will be our sentinel node number 1s and so on. So if the first sentinel nodes show that there is no tumor deposit there or metastatic cancer, then most likely the remaining sentinel nodes will also be negative because they drain sequentially. So if we had one that showed up positive, then most likely we would have other sentinel nodes that could also be positive. And I'll put up our next polling question here. So how should sentinel nodes be cut during grossing? Okay, I'm going to end the polling there. So yes, they should all be cut at 2 millimeter intervals. So here's a picture here showing the steps for cutting those sentinel lymph nodes. So we start with a little blob of fat there, and you can see kind of that gray brown discoloration of where the lymph node is. And then we'll be wanting to measure it and cut it at that 0.2 centimeter intervals throughout. And we'll submit the lymph node entirely. And it's really important to cut it this thin because the pathologist will be looking for any micrometastasis within these lymph nodes. So lastly, we'll just go through a couple prognostic factors for breast cancer, and I'll end with our last polling question here. So which of the following factors predicts a greater survival rate in patients with breast cancer? Okay, I'm going to stop the polling there. So it is D, invasive tubular carcinoma has the greatest survival rate for patients. And so we'll go through a couple other prognostic factors that can affect the outcomes. So for tumor size, that one's very important because increased size leads to an increased risk of axillary lymph node metastasis. Lymph node status, so axillary lymph node status is the most important prognostic factor for invasive cancer in the absence of distant metastasis. Going through the histology, so tumor type, like we had mentioned, some of the special types of cancer can have a better prognostic outcome versus the no special type. Lymphovascular invasion is a poor prognostic factor. Proliferative activity is also a poor prognostic factor. So the hormone receptors, so if it's triple negative, that's the worst type of breast cancer, and it's primarily because these patients can't get any targeted treatment. If it's a locally advanced disease, so if it's invading into the pectoralis minor or major or ulcerating through the skin, that will also be a worse prognostic factor. Inflammatory carcinoma, like we saw, is T4D, and that's the worst stage. And then presence of distant metastasis will also be a poor prognostic factor. So thank you guys all for attending today's session. Thank you, everyone.